when we first got shut down during the pandemic, we had to tell a lot of people they couldn't come in at all. And we did have telehealth visits available, but some people had no computer access. There was a lot of that work to set them up so that they could do a video visit. Others just had no computer. There was no option. And so we had to wait until we felt like we had safe practices to bring them into the office and meet their needs. We canceled all of our wellness visits, and we kept saying, okay, let's just move them back to July because I think it'll be okay by then. And then it wasn't. It was actually getting worse in July. And then we were like, we should have done this in April because it was a lot safer then, but we weren't sure of our own practices at that point. So we ended up opening back up to wellnesses in August. But at that time, we knew that people were going to get out and about more. The holidays were coming. We thought, well, there could be another shutdown, another quarantine. Well, then what are we going to do? So it was actually in August that we had a discussion and said, we've got to change to a method that will accommodate the patient, try to help the patient out here, because we've been accommodating us and keeping our staff healthy, keeping our place clean. Well, let's see, what would the patient want? They don't want to be rescheduled again. Okay, how can we set up a system that will allow us to be able to change things on the fly if the public health department says, no, you're closed again, but not make the patient reschedule their appointment. At that point, we had telehealth visits, so we could just flip it to that, and maybe they'd keep their appointment. But again, there were those few older patients or people that just had a hard time with the video that would say, no, I'm going to cancel. And then we also wanted it to be the same for the whole clinic. I take a little bit longer with my patients. Dr. Amijo's a little bit less time. We were training a new physician assistant and didn't know how long she would end up taking. So we decided just, okay, let's just set one visit duration for everything. And that kind of came out of the blue. It was like, well, maybe we could do two different ones. We were also talking about the online scheduling system at the time. And how are we going to make the rules so that people know what they can and can't do, but it's not going to create more work for in-office staff just in case somebody is out for quarantine themselves. We may be shorthanded. We want something that reduces our workload, not increases it or makes duplicate systems. So that seemed to solve all of those problems at once. Just one duration, every visit, get permission if you're going to tweak the schedule and talk to the doctor specifically. So we did that initially, and what we ended up saying was, well, yes, it's going to be a 30-minute visit. Our main goal at that time was to reduce the volume in the office. So we did layer on some 15-minute video visits on 30-minute visits just to see more patients if there was an urgent care need or somebody had a same-day need that we couldn't otherwise accommodate. But now that we've looked at it more, we found that 25 minutes is actually long enough. It still satisfies the reduced volume in the office because we do still have a scattering of telehealth visits, and we just set every visit to 25 minutes. It kind of throws the patients a little bit because they're like, you want me to there at 3:55? Are you sure? And actually we can say yes, because with the schedule, we've been able to stay on time a lot better. And we have such a long duration that we're never waiting for a room. They have the room for 50 minutes. So we can do EKG and lab and strep test, whatever they need before we need another room. Even with 2 rooms, we can turn over the room, get it cleaned, ready for the next patient, and stay on time within about 10 minutes of their visit.
So logistically, how did you begin to train your staff to think differently about this? And also, what kind of technical changes did you make internally to make this possible, such as computer schedules and things like that?
So initially it was just more rescheduling, but our schedules weren't that crowded in August because of all the rescheduling that had been done. And we just set a date, okay, September 1st, we're switching to 30-minute visits. So from that point, they started scheduling those and just adjusting the ones that weren't or leaving them there and extending the duration. So that part worked pretty smoothly. When we shifted again to 25-minute intervals, we had to change some of the start times of the physician's day. So Dr. Amijo moved back to 8:20, and I moved forward to 8:20 Mine was an 8:15 start, and hers was 8:30. So, and then our PA stayed at 8 o'clock. And so and then she's also offset in the afternoon to 1:15, the PA is, so that we don't have people crowding the scale when they're coming into the office. So there's a little bit of that strategic planning to make sure that the flow worked well. But in terms of the front office staff, it was, by that time, they were used to the 30-minute visit. And we already had some 30-minute visits on the schedule before we switched to everyone being a 30-minute visit. So that wasn't as big of a hurdle. The main one was that our EMR did not accommodate a 25-minute visit. You can only set it for 5-minute or 10-minute or 15-minute increments, and ours was set at 15. So with 5-minute increments, it was just ugly. You got this really long schedule. But we found that if we did 10 minutes, it would just look like the visit was overlapping a little bit, and they would be next to each other instead of one long line, which was much better. You could still get a good picture of what was going on without a 3-page schedule. So after we solved that, it was really smooth.
You've talked about keeping business out of the exam room. Can you talk about that philosophy a little bit more and the different ways it applies to your practice?
Yeah, that was a surprise. Once we weren't so focused on the schedule and on, well, what are they going to do to me next, I could really be more present with the patient and say, well, here's a patient that needs something from me. What is it, and how can I most effectively offer that to them? At the same time, I was reading some books by Brene Brown, and she talks about the fact that the platinum law is really the best way to deal with people, which is give people what they want in terms of treating them the way they want to be treated within ethical confines. But instead of the law of liberty, which is just don't hurt people and don't take their stuff, or the golden rule, which is treat you the way I want to be treated, this takes it to another level of, well, the way I want to be treated may not be the way you want to be treated. And I found where I was more comfortable and relaxed in this longer visit at the time, I was able to ask the patient, okay, in one instance, how many pills do you want? We're trying this new sleeping medicine. Usually I'd just do 30 pills because that's my practice. Okay, a month we're going to recheck it anyway. Let's just do a month. This guy had a really busy life. Even though he was retired, he was busy and he did not like going to the pharmacy. So he said, well, give me 90. It's not, the copay is the same for my insurance. Okay, I waste a bunch of pills if I don't use them, but then I don't have to go back again. And I told him, you've been on this before. It's something like the one you were on before anyway. So if it works, then we can do a 3-month follow-up because I'm not as worried about side effects or adverse effects. But I would never have chosen that. I would have said, I'm not going to take 30 pills, and if I try 2 and I don't sleep, I'm done. I just wouldn't do that. But that's what he wanted to do. And it was within an ethical construct. And so I gave him the 90-day supply. He called back a week later and said, this is not working for me. I need to go back to my old medicine, which we did. And I gave him a 90-day supply of that too. And I haven't seen him since. So, well, that's not true. He came in for something else. But anyway, went back to a 6-month follow-up. So it helped the patient. It helped me. It wasn't detrimental to anyone. And I was still following the golden rule because I was treating him at least as well as I would treat myself. But I was treating him better because it was the way he wanted to be treated. And I'm sure he's going to continue to be a very loyal patient.
It sounds almost like patient-centered medicine.
It does. It's a little bit different than what we're told that is supposed to look like. It's more about being in the exam room and saying, what does this patient need, and how can I really offer that to them? Another view of that is to say, I guess it's just a selfless thought process. We have so many things, so many boxes we need to check, so many hurdles we need to get through. It's easy to just worry about me. But when you feel like your practice is taking care of you, then it's easier to get out and say, no, I'm actually here to help you. That's why I went into this, was to serve people. But we get so caught up in the business of medicine, even in the exam room, that we're like, I'm stuck. I'm sorry, I I have to take care of this, and then maybe I can take care of you. But even just that one thing of taking care of, okay, I know what my schedule is going to be. I know I have a good feel for how long this visit needs to be. That allowed me to say, okay, what do you need from me? What do you want from me? And can I provide it to you?
Since you've become more cognitively present, what differences have you seen in your life and maybe even the lives of your staff since making this change?
Well, I think the anxiety piece is much lower. The staff also, they know that if they get an online appointment, it's just going to go right in. It's not going to add work to their day. They know they're not going to have to, if I have somebody cancel, they're going to be able to fill that visit with whoever calls for whatever issue. They're not going to have to find somebody to fit into that box. For me, I think the patient visit is more relaxed such that I get to know them better too. So in the layering of the visits as they come back in, I'll learn a little bit more about them each time so that the next time I don't have to ask or dive into how do they want to be treated. I know that this guy is a stock car racer. He's going to want a certain type of treatment, which will be different than this grandmother of 4 who is making things at home to sell at the farmer's market on Saturday. So those are things that I may not have learned in the past, which is sad to say, but I mean, you should be trying to learn about your patients every day. But if I got behind, which happened pretty frequently, I wouldn't take that time. That's the thing that got cut out because I'm able to stay on time and know my visit duration. I feel more comfortable starting out with that kind of discussion and not being rushed right into why are you here and how can I get you out of here soon.
Can you give me an example of how having more time with patients has allowed you to build greater trust with them and maybe something that has come out of that that might not have otherwise emerged?
Yeah, the one that comes readily to mind is a patient with anxiety. I'd been treating her anxiety for a long time, but I'd never really delved into why she was anxious, and neither had she. So I was able to do that once. It was a telehealth visit, so not as cozy as you might think, but she was in her home, so maybe that helped her open up. I don't know. But she said that she had a rough childhood and talked about what that looked like that led to her being afraid of the dark and afraid to fall asleep and needing medicine to help her fall asleep eventually. And it was eye-opening to me of, oh, well, that's something that can be solved. This isn't a permanent problem for you. It doesn't have to be. And it helped me identify what type of medicine would be better for her, which is something that addresses anxiety and sleep, not just sleep. So we've worked on that, and that's helped her with some of her other health problems to overcome those because she recognizes where her stress is from, and she's come to better terms with that. And I helped her to say that, okay, yes, you had a rough childhood, but you no longer need to be anxious now. You're in a safe place. You did better than your parents did for you. Look at your children. And it was eye-opening and rewarding to her too. The whole visit was very different than in the past, which was, are you having side effects? Are you sleeping? Is this lasting long enough? Okay, here's your refill.
So it sounds like you're moving really from practicing medicine as a commodity and back to reestablishing that connection between physician and patient that's really built on a relationship.
Yeah, and seeing the patient not as an object or a cog in the wheel, but as the subject of my discerning eye to try to figure out, okay, why did this piece of your body break down? And it's not always because of something that a medication can fix. And even if I can't address that, still just bringing that to the surface and having the discussions and the relaxed demeanor to welcome that type of information will then lead to better care over time and less medication mess ups or guessing wrong. Uh, it's just, I guess the Mayo Clinic does that pretty well because they have the time to spend with patients. Their view is that 90% of what the patient has wrong with them can be discovered in a history. And I think that's true. We just rarely spend 90% of the visit on the history because of time constraints and other things. But this really helped me to get back to that a little bit. The other piece is that the visit is billed according to duration and content. And this really helped me focus on what's the content of the visit rather than what is it supposed to be based on how long it was scheduled for. So that then allowed me to delve into, okay, yes, you're here for strep throat, but I notice you also have allergies and you've had a sinus infection every year. What can we do to prevent that instead of just addressing your 10-minute strep throat? And that gives a more whole person look. And by the way, my allergies are from my dog and my dog's dying. Maybe this is a time to not replace the dog because I get allergies from a dog, or get a hyperallergenic dog next time, which if you didn't make the time to talk about, you could miss an opportunity for something like that.
I am imagining that there's more than one employed physician out there who says, that's great, Dr. Foutz, but I'm not independent. I don't have the same flexibility you have. What would you tell them to speak with their maybe supervisor or administrator about to convince them there's a different way?
Well, I would sit down and look at the numbers. That's something that we did early on to see, well, how much revenue do we have per visit? And what number of visits per week do we need to have in order to hit that target? And then I would say, looking at the data, which I don't have the numbers yet, but I can see that this has been the case, your schedule will be more full if you have an open access system like this. So in the past, where you'd have gaps because you had a 15-minute visit that didn't fill or a 30-minute that didn't fill, you can fill anywhere a patient wants to be. And because of that, you may see just the same amount of patients per day that you actually saw before, even though you had a 20-visit option, because all 17 visits are filled instead of just 16 of your 20-visit day. So looking at the numbers, go back and say, well, would it really be different? And if all it is adding 25 minutes to the end of your day, well, you do that anyway. You're doing paperwork then. And this way you could actually go home when you're done with that last visit instead of staying at the office. Nobody else is around, nobody to help you, and you're just burning the midnight oil for free. This way you can say, I mean, I wouldn't bring that up with your employer, but that's really what's happening to employed physicians, and to tell them, hey, I can get the help I need from my staff. Patient satisfaction is going to go up because they're being more readily responded to in a timely fashion. And I will also not burn out. That's a huge deal. I mean, you can still burn out, but it would be less likely if you're not under the gun all the time and worried. I mean, that's a big deal. A lot of doctors are worried, and I have been in the past too.
Is there anything else about this methodology that you'd like to add that we didn't cover yet?
Yeah, I think just going back to that, it just allows you to feel some sense of taking back control of your practice. And you're not really taking anything, you're just structuring it in a way that you know what to expect. And as we learned from the pandemic, not knowing what to expect is more stressful than expecting something that's going to be hard. And that's been demonstrated in multiple studies. But that's true of every day in a doctor's office for many people because of the way their schedule is structured. And if that's all that we eliminate is getting rid of some of that unexpectedness of the day, and that lowers your cortisol levels, that's going to help you live longer. And then you will be more available for a longer time to more of your patients.
Well, congratulations on this innovation in physician vitality, and thanks so much for taking time to explain it.
You're welcome. Thanks for the invite.